Morning, everybody. I think we'll get started. Perfect. Well, thank you, everybody, for the opportunity to give grand rounds today. Today, we're going to be talking about goal-directed anesthesia in kidney transplantation. I think most of you know me, Chris Guan. I'm a career transplant scientist here in the department for 16 years or so. This is my co-presenter, Rohit Malyala, fourth-year medical student who's applying to urology this year as well. These are our disclosures, and note the land acknowledgement at the bottom here. We're going to be talking about goal-directed therapy in anesthesia and explore its application in urologic science as well as transplant surgery. We're also going to talk about specifically our research project that we've had in the area, looking at a VGH transplant cohort, exploring targets for GDT. And then we're going to, towards the end, look at how we can leverage machine learning techniques to analyze complex, large data sets such as coming from anesthesia. Speaking of anesthesia itself, I mean, the domain itself is changing quite a bit. A long time ago, they're really interested only in what happened in the OR, trying to keep patients alive. And over the decades and actually century, they've broadened their horizons to include immediate postoperative care, preoperative optimization, and acute care, as well as inpatient stay and now long-term outcomes. So the breadth of their purview is much broader, and their interest in producing outcomes of interest even after they see the patient in the OR has come to bear as well, which is great for us. Of course, their primary goal is to put the patient to sleep and wake them up, but their primary goal during the operation is to deliver appropriate oxygen delivery to the tissue in question. And goal-directed therapy is a kind of a modification of that goal, and that refers to a variety of targets and proactive techniques that one might do as an anesthesiologist to manipulate those physiologic targets. There's different ways to do it, and the proliferation of different monitoring approaches over the past years has meant that there's much more granularity in how we can view tissue oxygenation and targets for GDT. Those things might include things like stroke volume variability, pulse pressure variability, NIRS, transcutaneous O2, so on and so forth. But the number of levers that anesthesiologists can pull really fall broadly into a couple categories, those being fluid resuscitation and various forms of pressors such as inotropes or chronotropes. However, the different types that fall into these categories have increased as well. What is the utility of goal-directed therapy in general? This is not restricted to just intraoperative management, but perioperative management as well. They're generally heterogeneous in nature, but it seems to be most useful in high-risk populations or in populations where you're really defining the target population or the action specifically, such as with protocols. In terms of surgery, it seems to depend on the type of surgery, the type of patient that you're looking at, the physiological measure you're looking at, the intervention, and the outcome that you're trying to prevent itself. This is a meta-analysis of goal-directed therapy trying to prevent acute kidney injury in critically ill patients, suggesting that there is a favorable benefit to GDT in this population. What's the relevance of GDT in urologic surgery? Generally speaking, there are very few trials. We picked out two randomized control trials that provide the best evidence to date. One is in open cystectomy, looking to prevent postoperative ileus through GDT, goal-directed fluid therapy. So we have a fluid-restricted arm and a fluid-liberal arm. When you look at this paper that was published fairly recently in 2020, the fluid-restricted arm averaged about 1,800 cc's during the operation, and the fluid-liberal arm averaged about 4,800 cc's across the whole operation. So a fair difference, but there was no impact on postoperative ileus. Second randomized control trial looked at goal-directed hemodynamic management, which was a combination of stroke volume variation and other parameters in partial nephrectomy patients managed with GDT. And again, there was no difference between the primary outcome of AKI. Why would we go through the process of looking at GDT in transplantation? Well, whenever you hear a presentation about transplant, you always hear that demand always outstrips supply, and therefore every donor organ is a valuable resource. And over the years, the transplant community, I think, has done a really good job in terms of optimizing how we manage the deceased or living donor. And the numbers at the bottom of these figures indicate the number of publications over the past 20 years related to outcomes from, say, donor optimization, And I think we've done the same in terms of post-transplant recipient optimization, in terms of managing the patient holistically, social issues, and then very primary immunologic issues such as treatment of acute rejection or different types of rejection, management of delayed graft function, and so on and so forth. Over the past several years, we've seen the rise of ex vivo management of donor organs prior to implantation, and you can see the number of publications that has gone up recently. And this includes graft modification strategies as well as graft rehabilitation strategies. But you can also see that there's a gap in terms of intraoperative management linked to outcomes that have been published over the past 20 years. And I think that this is a space that we can operate in as surgeons. Of course, this is relevant because we're continuing to do more and more transplant operations year over year. UBC's kidney transplant program remains one of the largest in North America by volume. In terms of overall outcomes, we're overall doing a very good job. This is an analysis of the SRTR database recently, which is stratified by strata over 5-year cohorts, both for deceased donor and living donor populations, indicating that previously in 1995 to 1999, 5-year graft survival was around 60%. And in the contemporary cohort between 2014 and 2017 5-year period, we've increased that to around 80% or so. And that increase applies to live donor populations as well. So across the board, we're doing a better job, but not to say that there aren't negative influences on graft outcome that we do realize. So one of those things is delayed graft function, which is defined as need for dialysis within 7 days of transplant surgery. And the graph on the left indicates that if you are a patient that suffers an episode of delayed graft function during the course of your transplant, you are far more likely to lose your graft compared to in the green line if you never suffered that episode of delayed graft function. So it definitely has an impact on long-term graft function. And why are we seeing more delayed graft function overall? Well, it's because we're using more marginal kidneys. And more marginal kidneys from more marginal donors, such as DCD donors, are not nearly as resilient to insults along the transplant process as, say, non-marginal donors. And those insults might include things like warm ischemia time, cold ischemia time, ischemia reperfusion injury, hypotension episode, low flow states, and low oxygen states. In terms of the current evidence in GDT and transplant remains fairly weak. There's a few retrospective studies, which we've outlined a few here. But you can see that, say, Thomas and Kaufman's study indicate potential GDT targets between 80, maps of 80 or systolic blood pressures around 120 to try to reduce the incidence of delayed graft function. And Campos suggests a combination of both MAP and fluid resuscitation in terms of optimal management of the graft. But really, the evidence is weak overall. There just happens to be one small prospective trial in GDT and transplantation published by Cavallari recently. They use a SB optimization protocol and flow track sensor, which is a commercial type sensor used in the ORs these days, against conventional hemodynamic monitoring. In the graph on the right, you see in the blue line is the GDT arm. And basically it's showing that their patients received more fluids up front earlier in the operation and less later on compared to the other arm. The result is that there was a significant difference in terms of delayed graft function, reduction between the blue arm and the orange arm, which is GDT versus conventional. At this point, I'm going to turn it over to my co-presenter, who's going to talk about the results of our analysis of our VGH cohort, which I think you'll find the results interesting.
Hey everyone. So with a little more understanding of what the literature in the space of GDT and transplant looks like, we want to get into our work looking at transplant recipients' outcomes at VGH. So before the move to CST, you might have seen Dr. Nguyen taking photos of anesthesia records during donor nephrectomies and transplants. And over the last number of years, we've been digitizing these records and combining them with our own reference databases of pre-transplant donor and recipient data. This is all linked to the outcomes of the transplant patient. Between 2010 and 2022, we were able to collect this data on 609 eligible records with both, quote, static data and dynamic data. So static data, as we define it, is all of our typical pre-transplant data from the donor, the recipient, and the outcomes of the patient in the short and long term. And dynamic data is what we've been putting in the work to collect. It's the time series dynamic data from our anesthesia records. We then fed this into two main pathways of analysis, what we call a classical pathway and then also a machine learning pathway. where we use ML techniques to actually make our insights. So we'll talk about the classic analysis first. Our first aim was to simply take the time series data and graph it, just to get a sense of the typical patterns of blood pressure variation at different time points throughout the surgery. So on the right, we have a graph of the average mean arterial pressure in kidneys with DGF, that's the solid line, and without DGF, that's the dotted line. And this was averaged between all of our surgeries on recipients with DCD kidneys at each measured 5-minute interval from the anesthesia records. And then the gray box here represents the average start and average end time of anastomosis. So it's possible to also infer changes in hemodynamics around that important event. As a note, while we're here, over the rest of the presentation, you're going to hear our discussion often center around blood pressures at or after the time of anastomosis, because we feel that that's the most important period intraoperatively for the newly transplanted kidney, because it's the first blood flow that the new kidney sees. Also, it represents a time point in the operation, which allows for optimization work to be done in a paced and controlled manner. So with this approach of directly graphing the average blood pressure courses, we can note some interesting trends in surgeries that result in DGF and then surgeries that don't result in DGF. First, we have this analysis divided between surgeries done in recipients of LD, live donated kidneys, NDD, neurologically determined death kidneys, and then DCD, or donation after circulatory or cardiac death kidneys. And there's some, and we did this because the physiology between these groups and the incidence of DGF is known to be quite different. There are going to be some significant differences that point to different drivers of DGF in the three groups as far as blood pressures are concerned. So in live donor kidney recipients, those who have DGF have lower blood pressures, vastly lower blood pressures just before and at the time of anastomosis. In NDD recipients, on the other hand, there doesn't really seem to be that much of a difference between the blood pressures between the two groups at any point throughout the surgery. And perhaps that suggests that the DGF in NDD recipients is more attributable to the input quality of donor kidneys than any specific intraoperative event. And then finally, in DCD recipients, we see that on average, the blood pressures are consistently lower in those with DGF than those without throughout the entire operation. Now, of course, given that the data is all retrospective, any of the observations we make here and afterward as well should be considered hypothesis generating, but it's still pretty interesting to take a look at this kind of stuff. We also performed a similar analysis looking at the use of IV crystalloids administered throughout the surgery, and we can continue to make these interesting observations. So in live donor recipients, those with DGF received substantially greater infusion rates of fluids, all quite prior to anastomosis. In NDDs, the crystalloid infusion rates are roughly similar, but despite the average blood pressures being virtually identical between the two groups, we do see that the DGF group did receive on average higher rates of crystalloid compared to the non-DGF group just before and during anastomosis. And then finally, in DCDs, there are really minimal differences in fluid use between those who did have DGF and then those who didn't. In the next analysis, we plot here the proportion of DGF incidence across intervals of the patient's average MAP post-anastomosis. So the graph is split between DCDs who are in triangles, live donor recipients in circles, and then NDDs in squares. And then the numbers that you're seeing inside the legend is basically the sample size for each group. So taking a look at this data, live donors had very low DGF rates overall, which makes sense. And NDD recipients have a very minor increase in their DGF rate as the mean MAP range post-anastomosis gets lower, just a minor increase. But for DCDs, we see that while at high post-anastomosis MAP, somewhere in the range of above 85, above 90, the DGF rate is low. So it's actually 20 to 25%, pretty close to NDDs. We see that once you drop below a mean MAP, less than 85, the rate jumps to near 50%. And then for every subsequent decrease in the MAP interval, the incidence rises slightly higher and higher and higher. Now, one question that anesthesiologists may often hear in the OR is Dr. Nguyen or Dr. Harriman asking, what was the patient's baseline blood pressure? In graph B, we show the mean MAP, but this time as a percentage of the recipient's baseline blood pressure. And while we don't see that sharp jump like we did in the previous graph, which was graph A, we see that for DCDs, maintaining a mean MAP greater than 90% of the patient's baseline blood pressure results in a reduced amount of DGF. So this is approximately 25%. And then if you go below 90%, then it starts to approach 50%. So there's a suggestion of a target. There's a potential target there of trying to stay at 90% or more of the recipient's baseline blood pressure. And then for NDDs and LDs, there's again not as much of a change in the DGF incidence regardless of the map until you get very low. Furthermore, in transplant, we can also examine the blood pressures, not just in the context of the recipient's baseline, but also of the kidney donor's pre-op baseline blood pressure, whether they're a living or deceased donor. And so that's graph C, where we express the mean map as a percentage of the donor's pre-op baseline map. And then for DCDs, we see again a potential target of trying to stay at 90% or more of the donor's baseline blood pressure, or else your DGF rate goes from approximately 30% to over 50%. And then also, interestingly, for live donor recipients, while the event count is low, there is a jump in DGF incidence when the map drops below 80% of the donor's baseline, which points to another potential target there. Also, instead of looking at only the mean map post-anastomosis, we also repeated the analysis with taking the lowest map recorded post-anastomosis to investigate like multiple measures of hypotension. Again, the general trends we're seeing are preserved, and there's not too much of a difference using mean map or lowest map. Next, recognizing that DGF is mainly a surrogate of important long-term outcomes, in this next analysis, we wanted to specifically look at medium to long-term outcomes as well. So on the left side, we have the differences in serum creatinine drop-off in 1 to 7 days post-transplant, and then 14 to 60 days post-transplant, between those who have a map of greater than 75, those are the dark boxes, versus people who have a post-anastomosis map of less than 75 millimeters mercury in the lighter boxes. And then we faceted the analysis between DCD recipients and NDD recipients. And there were no major differences in serum creatinine post-transplant, despite these differences in intraoperative blood pressure in either the short or long-term post-op periods, except for DCD recipients and only in the first 7 days. By 14 to 60 days, even the more hypotensive DCD recipients would have roughly equal creatinine levels. And then in the further long-term, we've calculated these Kaplan-Meier survival curves for the same populations. And again, we're showing no differences in graft survival regardless of the post-anastomosis map. And this is a 5-year follow-up. So the survival curves in both of these groups are almost completely overlapping. For visibility and space, I didn't include results on live donor recipients, although they also didn't demonstrate any divergence in either the serial creatinine or the 5-year graft survival. Now, one struggle that we have with discussing these topics is that all of the variables are highly intercorrelated. So to get a sense of how the important variables are interrelated, this next analysis is a logistic regression of the average map versus DGF incidence. But this time, we're controlling to see how the risk curve changes based on how much pressors a patient got during their case. So our pressor of interest was phenylephrine because it was the most commonly used pressor. Now, what this graph suggests is that there may be a bit of a sweet spot for pressor use. So black here is the baseline risk curve where a mean quantity of pressors was used. That was about 400 micrograms. And then the lighter line is -1 standard deviation, which is 0. And then the colored line, the yellow line, is +1 standard deviation dose of pressors. So that's 1,300 micrograms. And the signal we're observing is this. When the map is below this intersection point of 75, when more intense doses of pressors are used, the DGF rate in orange is lower from baseline, which is black. And that makes sense because responding to hypotension with more intensity of pressor use is good. But if the pressors are maybe used too liberally or too early when the map is greater than 75, then that more intense pressor use, even though it is driving the blood pressure higher, may actually increase DGF rates from baseline. So we can perhaps generate this hypothesis that high maps might be better overall, but using increased doses of pressors for achieving that might be detrimental. We repeated this analysis, except this time with cumulative IV fluid doses administered within the surgery. And the black line, again, is the baseline. It's the mean total crystalloid received during the surgery of about 2.5 liters. The blue line is +1 standard deviation. The light line is -1 standard deviation. And the same relationship is visible here. So below this intersection point at 75 millimeters mercury, responding to the hypotension with more intense fluid therapy or greater dose of fluids reduces DGF incidence slightly. And then the reverse is true, where a higher fluid dose increases DGF incidence when you're at higher MAPs. So again, there's a suggestion of a benefit to proper timing and proper dosing of these interventions, whether that's IV fluids or vasopressors. Now, the complex regression analysis in the last two slides is really just part one. It's a start in our attempt to really tease apart the complex relationships in our data. And this is where we start to use a machine learning approach. Anesthesia data sets can be really, really large, and there can be many complex relationships between all the different variables, especially when you look at time series data. And ML, even rudimentary ML, can actually model these complex relationships quite nicely compared to more conventional analysis like logistic regression. And that gives us better predictive ability in our models. The other interesting thing is that ML models can also be interrogated in special ways to make it explain how it got to those predictions. And we'll visit that idea in just a bit. The problem that we're trying to tackle here very broadly is called a classification problem. We're trying to make a model that associates certain patterns of anesthesia management to the incidence of DGF, which is a binary outcome. And again, we've collected a wealth of data that's suitable for ML analysis from all of these anesthesia records. And on our prepared data, we extracted a bunch of relevant features from the time series data, and then we combined it with all the pre-transplant static variables. And overall, our data set came out to about 180 features or variables on over 600 patients. We then took that prepared data and ran it through an ML classifier called XGBoost. It's considered state of the art. And one of the reasons it's really good is because it tends to not overfit even when you have hundreds and hundreds of variables that may be quite strongly correlated with each other. And this is in opposition to a typical classifier like a logistic regression model. Now, the first thing we did was we characterized the accuracy of the classifier by testing it on a holdout portion of the original data set. And the overall accuracy is good. It's a little over 80% accurate at predicting the incidence of DGF, with a sensitivity of 70% and a specificity of 82% for DGF. But what we're really interested in is, now that we've kind of established the baseline predictive value of the model, is how the model arrived at its conclusions. And that's where these so-called SHAP explanatory analyses come in. So these are the results of the explanatory ML model in a quote B swarm plot. And it's pretty information dense, but we'll walk through it. There's only 3 things to understand in order to interpret the plot. So of 180 original variables, we're seeing only the top 10 most important variables here. Top to bottom, most important to least important. The second thing to know is that each dot you're looking at it represents a patient that the model is making a prediction for. And red means that that patient had a high value of this particular variable, and blue means that they had a low value of that particular variable. If it's a binary variable like NDD status, red means yes, blue means no. And then the last thing to know is that with the negative SHAP values off to the left, you have less DGF. And then with the positive SHAP values off to the right, you have more DGF. Now, at the top of this plot is cold ischemia time. It's listed as what the model thinks is the most important factor in DGF incidence. So low cold ischemia time in blue is associated with better graft outcome. And that's fairly well understood. So we feel that it shows that the model has this good face validity. When you look down one, however, an interesting result we got in this run of analysis was that one of the most important variables for predicting DGF was MAP threshold for pressor. So basically, during the anesthesia records, we were able to calculate on average for each surgery how low the MAP had to be in order for an anesthesiologist to decide to give a vasopressor. And it appears that the higher the average MAP was at the time that a pressor was initiated, either as a bolus or as an infusion, the worse the patient did. And then if we go down a few more, we can see that we have mean IV crystalloid infusion rate also listed as a top 10 factor in making predictions. And it seems that high infusion rates were associated with DGF incidence, but also low infusion rates were slightly associated with DGF incidence. It's on the right side. And then all the moderate values, all the purple dots indicating the moderate values of infusion rates are more so to the left, meaning that maybe moderate infusion rates were associated with the least amount of DGF. Now, overall, the takeaway from this figure is that there's a bunch of OR-related actionable parameters that rank highly for contributions to DGF incidence. But we can actually go one step further than this. We can investigate the details of these surgically actionable parameters by constructing SHAP quote dependency plots. So the dependency plot we're looking at here is for map threshold for pressor use. And then the SHAP values are here again, but this time they're on the y-axis, but still -1 means less DGF and +1 means more DGF. Now, the first thing to note is that all the people that didn't actually need a pressor are clustered off to the left, and they had the lowest DGF incidence, which makes sense because they didn't need a pressor to maintain their blood pressure in the surgery. But interestingly, though, there's, again, some neat, potentially actionable cutoffs for pressor use. So looking at this graph, it appears that the people who had the most DGF, they tended to have their pressors given to them at either low map thresholds, below, let's say, 63 millimeters mercury, or at high map thresholds above 73-ish millimeters mercury. And then those who received a pressor between those 2 points, that range, they appear to do better. So this could indicate, as far as a retrospective analysis would allow us to comment on, that there's a bit of a potential sweet spot for the timing of a vasopressor in a transplant surgery. And again, perhaps when used too liberally or too early, the renal vasoconstrictive effect reduces renal blood flow, and when used too late, hypotension itself, of course, is bad for renal blood flow. And this is going to be our last analysis. The last variable we'll take a closer look at is IV crystalloid infusion rates seen throughout the surgery. And again, there seem to be some potentially actionable ranges for IV fluids use suggested by this ML analysis. So here we have low mean crystalloid infusion rates, less than 500 cc's per hour, which is in this area here. That was associated with higher DGF. And then high mean crystalloid infusion rates, greater than 750 cc's an hour, were also associated with higher DGF. And then the patients in the middle here with more moderate infusion rates between 500 and 750 cc's an hour, they appear to do the best. And perhaps the theory here is that excessively high fluid infusion rates maybe lead to an interstitial edema in the graft, reducing perfusion, and then in the other direction, excessively low rates reduce the effective circulating volume, reducing renal blood flow. So to wrap up, some key messages that we want to impart after all of that analysis are that intraoperative blood pressures, pressor use, IV fluids, they're all important to the incidence of DGF, and they're all really tied to each other and related to each other in a complex way. And hopefully by undertaking analyses that respect those intercorrelations, either with or without machine learning, we can help structure future decision-making in manipulating these physiologic targets and then hopefully move closer to maximizing the benefit from each and every kidney donation. And the ideal is that these complex analyses will give us avenues for further exploration, and it'll allow us to appreciate better the implication of the effects of our actions in the OR on patient physiology at a very deep level. And as far as future directions, we're eager to be continuing our work in the ML arm of the analysis, and we're especially trying to leverage the time series nature of the data. We'd be really interested in collaborating with others from our department regarding any future prospective studies and potentially doing this type of analysis for other types of urologic procedures. Thanks for listening.